Hi, my name is Pete Now. I am an associate professor of surgery at University of Iowa Hospitals and Clinics. I'm here with Dr. David Rattner, who's a professor of surgery at Harvard Medical School and the chief of GI surgery at Massachusetts General Hospital, and we're just going to be interviewing him as a part of the SAGE's Trailblazers and Surgery video series. So, Dr. Rattner, thanks for taking some time to meet with us today. I just have a couple questions for you, because you've been a big mentor for me and really someone that I've modeled my life about a lot, not only in the clinic but outside the hospital. And I think one of the things that you always wonder when you're thinking about your mentor is, who was someone that you looked up to, or who did you look up to when you were growing up? Was it an esophageal surgeon, or was it your dad, or, I mean, who made you become what you were today from physicians?
My dad was a physician, and that probably helped me sort of frame or at least understand what it took. But I wouldn't say he was my mentor. I think my surgical mentor definitely was Andy Warshaw, who was a true general surgeon but became very famous for his work in pancreatic surgery. I think we both had a little bit of a rebel streak in us, and loved sort of, when I was a resident, working with him just to find some dogmatic statement or principle and see whether we could knock it down. And so that sort of rebel streak resonated with me, and he was just a tremendous surgeon. He is a tremendous friend, and I would say he definitely was my mentor at Mass General.
And did you stumble onto esophageal surgery? Because you do a little bit of esophagus and a little bit of colorectal, which is very uncommon.
Yeah.
Is that something that you always saw yourself doing, or did you just sort of stumble on it as you went and your practice matured, or how did you see yourself starting compared to where you finished?
You know, when I was a resident, I was sent to the laboratory. I was sent to do gastric physiology, and I spent 2 years in the laboratory of William Silen, who was a famous GI physiologist and chief of surgery at Beth Israel. And as I was finishing my residency, Dr. Jerry Austin recruited me to stay in Boston. I never imagined I would stay there. And so I started off on that pathway, but when I was doing my super chief year, I was interested in pancreatic disease and pancreatic problems, and so there was a little bit of dissonance between what I was being recruited for and what I was really interested in, and my own research during the first couple of years didn't progress as rapidly as I had wished on terms of the gastric physiology, and I was talking to Andy quite a bit, and I started to do some projects with him, and so my lab focus shifted from gastric physiology more to acute pancreatitis, and that's kind of how we began our relationship, and we had a fair amount of success in laboratory and clinical publications. But really the key step was I was giving a poster on acute pancreatitis at, I believe it was the American Pancreatic Association, next to another young surgeon who I had befriended named Carl Zucker. And Carl and I had a social relationship as well, and we were out for dinner. I think he said, you know, if you could, you should come down to Baltimore next week. I'm going to do something really crazy. I think you'd enjoy it. And it turned out it was laparoscopic cholecystectomy. And so I came and I watched him do a couple, and I came back to Boston and I said, Andy, I'm going to do this. We have to do this. And he said, it's crazy. And I said, no, if you trust me, I think this is going to be really big. And at the end of the day, he backed me up, and we got started on doing laparoscopic cholecystectomy. We were one of the first, if not the first, in Boston to do it. And through Carl Zucker, I immediately jumped into laparoscopic Nissen fundoplications. At about this point, one of my co-resident fellows came back, Charlie Ferguson, and Charlie and I began doing some laparoscopic Nissen fundoplications together, and then off we went. I guess it's a question of being in the right place at the right time, because John Hunter actually had been my surgical endoscopy fellow as a year or so younger when I was the super chief, and I had a good relationship with John, who told me about SAGES before this, or about when this was happening. And so I developed sort of a squad, in modern parlance, of good friends of Nat and Nat Soper, John Hunter, Lee Swanstrom, Joe Peatland, Bruce Shermer, a bunch of us who were the early sort of folks who were doing laparoscopic surgery. And it goes back to Andy Warshaw, because people said you shouldn't do this, and we got a lot of grief about it, and it wasn't safe, and it wasn't this, and it wasn't that. But patients were flocking to us, and we were a big threat to them because we were not trying to take away their practice, but the fact of the matter is we were doing 10, 11 laparoscopic cholecystectomies a day, and people were just beating down the doors to have it. And I think, in all fairness, that we did this in a safe manner. It's not the way we would do it nowadays, but at least in my inner circle of colleagues there, we were pretty thoughtful as we went about this. And that's how it all started. How it ended up being so much foregut and esophageal, you just kind of what you get known for. When Lap Heller came along, I was the only guy in the hospital doing it, and so that just led to it. And then the other factor, which is very different today than it was, and I finished my super chief here in 1985. At that point, we did a lot of thoracic surgery, and I served as the acting thoracic chief resident for several months, and so I had plenty of thoracic experience. I wasn't afraid to operate in the chest. Right. It was just a different kind of a training, so it seemed very natural to me, and as long as my results were good, nobody bothered me about doing a thoracotomy, and so that's how it went.
So, it's really interesting for me because you read the articles about the people that start laparoscopy, and it was just crazy how they were, the process and they went through to teach themselves how to do it. And you're one of those early folks. Was there a time when you were like, this isn't what I thought, it's not going to take off, or did you always see it where it is today, where it's really the gold standard? Was a learning curve?
Yeah, I didn't quite see everything quite going this far as it has, to be honest with you. There's just such a huge difference in terms of outcomes with laparoscopic cholecystectomy versus open that was fortunate to have that huge gap, and it was actually very patient-driven. Laparoscopic colons, when they began, were much more challenging, and I think there are other people that deserve a lot of credit for making that happen. I think we've almost gone to the opposite extreme, and now the residents that we see have a lot of trouble with open surgery, and I never thought I'd say it, but it is important to be able to have that tool in your toolkit. And so as I see people spend 6 or 7 hours robotically, laparoscopically, it drives people my age a little bit crazy, because of course we could make an incision and usually complete things. And in fact, one of the last papers I've written had to do with open surgery for complicated hiatal hernia repairs. And if you looked at the results of those patients, they're spectacularly good for very difficult operations. So I think that if anything, it's gone farther than I would have imagined, and it's unclear what the place of open surgery will be in the future, but at least in my hands, there's still a place.
Yeah, definitely. When you took, now lap chole is always going to be a little bit more straightforward, but when you talk about this, the complex foregut, were you just taking your open operation and replicating it when you started laparoscopically, or what was that learning curve like? Because it's distinctly different operation lap. Did you have to sort of invent on the fly, or what was that process like?
Well, it was a little bit of trial and error, and don't forget, at that time there was no really good digital images. We were literally passing VCR cassettes back and forth to each other, or DVDs when DVDs came along. So we would go to meetings and we would share our experience. So there was a lot of sort of sharing. I did this and I did that, or you did this, and why don't you try it this way? Or I'm going to come and fly out to Portland and see what you do. And you come to Boston and you see what I do. So there was no, the web existed, but no one used the web like we do now. So it was really a lot of, it was clubby, is what I would say. And if you were in the club, people told you their secrets, and then you could try them out. And it turned out, for foregut surgery, that the development of the harmonic scalpel was a tremendously important enabling step. Because when we began, we'd have to place these little clips on the short gastrics, and sometimes they'd fall off, and it wasn't easy to stop the bleeding, or you could have a splenectomy. But as the equipment improved, and the energy devices in particular improved, it became a much easier operation. And in fact, it's much easier to do a lapness than an openness, and just because of exposure issues.
Yeah. What do you think has been the biggest thing? Has it been, one of my staff when I was in residency used to talk about Bovie being, the groundbreaking thing for surgery because of, energy devices and how it changed how we eat hemostasis. From a laparoscopic standpoint, has it been the optics? Do you think it's the harmonic energy devices, or what do you think has been the thing that's facilitated the growth? Is there one thing you can put on, or is it just too many?
No, I think the key ones are the energy devices, whether it's harmonic or whether it's bipolar, ligature, harmonic, whatever. Those make a tremendous difference and allow you to do things, even sometimes in open surgery, that would be very difficult to do just with a clamp and a ligature. But the stapling technology was also critical to make a big leap forward and to come up with good stapling devices. All the metabolic and bariatric surgery is enabled by the advances in stapling devices, for sure.
Yeah. So, one of the things that I was always interested in, which really drew me to your fellowship in particular, was the idea of innovation, because, Dr. Melvin was someone that taught me as a resident, and he was one of the big doctors early, the robot, and then you were very early in on the notes research. What do you think is the next big thing? Is there the next big thing? Is it already out there? Is it POEM? Is it links? Are these devices or approaches going to be, or do you think we even know what it's going to be? Because I feel like at some point, innovation becomes difficult because of the society or the financial environment that we're in and the medical legal environment. Is there something that you think that's out there now that's going to be the big thing, or do you think it's sort of?
Well, I think that it's, if you're looking to what happened in the past, you're looking in the wrong place. And that's just not innovation, and that's why you have a concept that disruptive innovation is unknowable. You can do all the market research that you want, but even market research looks backwards, not necessarily forward. To me, something that's going to be based on big data, machine learning, AI, and I would say genetics, targeted therapies, targeted surgery, whatever, I think that's the opportunity. I don't think anyone's quite put it all together yet, but it would seem that those are the technologies that are going to change the way that our 25 and 30-year-old surgeons and surgical trainees will practice. What you finish doing when you finish your career 20 or 30 years from now, I will bet you doesn't exist at the moment, because what I did didn't exist when I trained, and the pace of change is ever increasing.
Yeah, I think about my practice is so little with a robot, and it's, a lot of the people that train me just have never been, they've always done it with the straight sticks, and I don't know if I'm fighting something, or if the pendulum has swung so far the robot that it's going to come back, or if there's going to be some iteration of the robot that's different than what we have now.
Right now, the robot is it's a master-slave system and has really good optics, but it doesn't do anything that you couldn't do yourself with your hands. And so we haven't really taken advantage of the computer in the robot, at least as far as I'm concerned. And once we do capitalize on the computing ability and ability to learn or interpret data which you can't with your brain process fast enough, then I think we're really going to have something special. So there's no question in my mind that computer-assisted surgery in some form is important and will be a key part of the future. Whether it's the Da Vinci system, I don't think so, to be honest with you. But the Da Vinci system married to the good use of the computational power, then I think we're going to have something.
So, I think there's definitely two aspects of you, and I think one of them is clearly the clinical part, but the other thing that I've always really admired, and we got to go see Bruce Springsteen when I was a fellow,
okay.
And I got to go see the Bruins games with you.
Yeah.
Like, you've always had a healthy grasp on when to work and when to play. Was that something, who taught you that? Was that something that your wife was like, listen, make time for the family, or was that something that you saw with your parents? Where did you learn how to play hard and work hard? Because I think that's probably one of the most important things I've learned from you.
Not from my wife. She works harder than I do, and God bless her. But it's just in my nature. I have trouble doing things halfway. And in college, if we partied hard, and if we worked hard. And I guess I am still immature enough to, when I party hard. That's just the way I roll.
Well, thanks for taking the time to meet with me. I think that, you've been a huge part of so many people's lives, whether it's, your fellows or your surgical trainees. And, I think when you look back in the next couple of years, it'd be interesting to see all the people as they grow up, and you see more and more people that are chiefs and medical directors, because I think that you've influenced a lot of people, and it was great being trained by you, for sure.
Thanks, and I certainly enjoyed our year together immensely, and continue to enjoy your football insights too.
A little I have.
Yeah, thank you, Peter, very much for your kind words.